Well, welcome everyone. I am so glad that you've joined us today. If you are here for our training and discussion on the equitable enforcement and commercial tobacco control, then you are in the right place. My name is LaTroya Hester, and I'm the Director of Communications for the Center for Black Health and Equity. I'm so excited to report that this statement that we'll be talking about, which many of you have already seen, has now been signed on to by about 45 organizations. The values that are listed here really do represent a commitment to protecting youth and Black and brown lives, and I believe that it sets a precedent for other public health entities to follow. Today, it's my pleasure to introduce you to our speakers, but before I jump into that, I want to note that we will have a Q&A toward the end, so feel free to pop any questions you may have in the chat located bottom left where it says Ask Questions. And you can also use that chat box if you run into any technical issues. Now I'd like to go ahead and let you know who you'll be hearing from today. Molly Mayfield is Senior Project Director at CounterTools and Managing Editor of CounterTobacco.org. She works with CounterTools partners across the country, providing technical assistance, training, and consultation on policy change for improving the health of the retail environment and advancing health equity. You'll also hear from Derek Carr, who is a Senior Attorney at ChangeLab Solutions. Derek works primarily on issues related to substance use and addiction, including overdose prevention, harm reduction, and commercial tobacco control. His work also focuses on preemption and health equity across issue areas. Del Monte Jefferson is the Executive Director at the Center for Black Health and Equity, my boss, and he has worked with national, state, and local legislators to help shape policies in support of smoke-free establishments and restrictions on the sale of menthol and other flavored tobacco products. And last but certainly not least, we're going to hear from Carrie Mcfarland. She's the Program Supervisor for the Tobacco Control and Prevention Program in Multnomah County. She's going to offer some context and some practical application of the recommendations in the statement, and I think you're going to get a lot out of that. So without further ado, I want to pass the mic to Derek Carr.
Thanks, LaTroya. So for those of you who haven't worked with us before, ChangeLab Solutions is a nonprofit that works across the nation to advance equitable laws and policies that ensure healthy lives for all. We prioritize communities whose residents are at highest risk for poor health, and our interdisciplinary team of lawyers, planners, policy analysts, and more work with neighborhoods, cities, counties, and states to create thriving communities. Now, before we get started, I have to give the spiel. While I am a lawyer, I am not your lawyer. And at ChangeLab Solutions, we don't provide legal advice or enter into attorney-client relationships. And I also want to note that the views I'm expressing today are mine alone and do not necessarily reflect the official views or policies of the U.S. government, including the Department of Health and Human Services. So why are we talking about equitable enforcement today? What does equitable enforcement mean? Why does it matter? And what can and should public health professionals do about it? So looking at that first question, what is equitable enforcement? I want to back up for a moment and recognize that there's a significant gap between the promise of our laws and people's lived experiences. This gap exists in part because laws designed to keep people safe and healthy are often not enforced, and when they are not enforced equitably in a way that promotes health and well-being for the most marginalized. Enforcing actions taken in the name of public health can sometimes harm, discriminate against, or otherwise undermine the health of the very people the laws are meant to protect. In fact, when enforcement is carried out inequitably, it can create, maintain, or exacerbate existing health inequities. On the other hand, equitable enforcement is a process of ensuring compliance with law and policy that considers and minimizes harms to underserved communities. An equitable enforcement approach means considering equity both at the level of the public entity's overall enforcement strategy and at the level of individual enforcement actions. It also means considering equity at all stages of enforcement, from determining when to undertake an enforcement action and against whom, to deciding which enforcement tools to use. Ultimately, equitable enforcement can hold wrongdoers accountable while simultaneously protecting the health and well-being of individuals and communities. When we talk about inequitable enforcement, we're usually looking at two separate concepts, over-enforcement and under-enforcement. Under-enforcement occurs when laws that are designed to protect communities are not consistently enforced, and most often those laws aren't enforced in already marginalized communities. So the housing context offers several examples. Fair housing laws and local housing codes are laws that are designed to protect the health, and safety of the public by ensuring safe and habitable housing. But these laws are systematically under-enforced for a variety of reasons. Environmental laws that protect clean air and safe drinking water are often unenforced as well. And we can just look to Flint, Michigan as one of the most prominent recent examples of the horrific health and equity impacts that can result from the failure to enforce such policies. At the other end of the spectrum, over-enforcement occurs when laws are enforced more frequently or more strictly in certain places or against certain people as compared to others. And data suggests that the over-enforcement of laws can adversely impact health and compound existing health inequities by exposing the person to even greater harms than what the law was trying to protect against in the first place. And over-enforcement can mean the strict enforcement of laws even when it doesn't necessarily further a public health goal. So we can think of school zero-tolerance policies, right, that can result in widespread and inequitable suspension and expulsion even for relatively minor offenses. And it can also mean that the laws are directed at individuals rather than the systems and actors with real power to make meaningful change. So what are some of the common mechanisms through which public health laws are generally enforced? First, you have administrative enforcement, which is where an administrative agency, like a health department, can issue a citation or notice of violation, hold an administrative hearing to consider the evidence, and then determine whether a violation occurred and what the penalty should be. This is normally an administrative fine or the revocation or suspension of a license or permit. And as all of you are likely familiar, tobacco retailer licensing is a great example of something that's often enforced in this way. Next is civil enforcement, which is where a jurisdiction can file a civil lawsuit to enforce a law, remedy a wrong, or protect a right. So if someone's violating a law, the jurisdiction can sue for an injunction, impose civil penalties like fines, or both. And evictions are a common civil enforcement action, so we can think about that in the context of, say, smoke-free multi-unit housing. Last is criminal enforcement, which is what most of us picture when we think about enforcement in general. And that involves criminal prosecutions with penalties ranging from fines to imprisonment. And policymakers really need to pay special attention to the impact of criminal sanctions when drafting enforcement provisions, because over-reliance on criminal enforcement can exacerbate inequities and prompt unnecessary interactions with law enforcement in underserved communities, which may already mistrust police and other institutional actors due to both historical mistreatment and persistent disparities within the criminal legal system. So when we're looking at the enforcement of laws and policies, there are several different aspects to consider. The first is who can enforce the law. Are the police the main enforcement body? And does having police as the enforcing body further public health goals of the law? Or are there other entities other than the police that can enforce, especially those with missions that are more aligned with the underlying goals of the law? So health departments enforcing public health laws, for instance. Next, who's targeted for enforcement? As an example, as we'll hear about later today, we can think about whether enforcement is targeting general individuals, like people who use tobacco products, or on the individuals and entities with power to make change, like industry actors. Victims and communities can also play a role in enforcement in design, implementation, and practice. There are investigative and adjudicatory processes, so thinking about things like the potential for compounding penalties, proactive versus reactive enforcement models, and the entities responsible for those processes. And then there's the range of sanctions, which includes things like fines, criminalization, education, eviction, and non-punitive options. And we want to think about the health impacts and potential unintended consequences of the applicable sanction. It's also important to keep equity front of mind when initially formulating, drafting, and eventually adopting a law or policy. So one of the first things to keep in mind is graduated enforcement. So some policies include graduated penalty schemes where people who violate a law may be subjected to less serious consequences like a warning or education before more severe consequences will be imposed. Next, as I mentioned a moment ago, there are the range of sanctions. So government officials can, for example, consider for laws that impose mandatory fines using a sliding scale or proportional fines that reflects the financial circumstances of the violator. Government officials can also consider drafting enforcement provisions that incorporate non-punitive consequences like education and restorative justice models. And policymakers would also want to be careful in considering who the enforcing body is going to be and be really intentional about community impact and potential negative consequences. And finally, it's important to consider guardrails for discretion. Agencies and enforcement officers have discretion in which policies they pursue and how they pursue them, while individuals have discretion in whether they choose to enforce the policies and against which actors. And while discretion can, in many instances, lead to inequalities, it may also be impossible to eliminate entirely. To the contrary, eliminating all discretion can be equally problematic, right? Leading to outcomes like mandatory minimum sentencing or zero tolerance policies that don't allow for adjustment in order to ensure the best outcomes. But enforcement policies can aim to limit the potential negative impact of discretion with careful planning. So these guardrails for discussion can guide enforcement officers in their decisions and promote better implementation and enforcement practices. Now, there are a variety of other considerations to keep in mind when thinking about equitable enforcement as well. And we have a lot to cover today, so I don't want to cover these in great detail, but they include community involvement in design and evaluation, data collection and ongoing evaluation, ensuring adequate funding for enforcement, the ongoing training for enforcement officers, and policy updates based on that ongoing evaluation process. So with all this information about equitable enforcement, what are some of the roles for public health practitioners? First is making the case. As trusted leaders, public health practitioners are well positioned to make arguments as to why enforcement practices, whether equitable or inequitable, are a key contributor to health outcomes and health inequities. They can also provide support and technical assistance to build capacity for others, community members and allied organizations, for example, to make the case for equitable enforcement, engage in the policy process, and identify opportunities to redress existing laws and policies that create or reinforce inequities. And in many jurisdictions, government public health practitioners, like state and local health department officials, can directly engage in enforcement activities themselves. And finally, there's research and evaluation, which are, of course, always core components of public health practice. And that's true in this context as well. So what does all this have to do with tobacco? So last summer, several leaders within the APHA, Alcohol, Tobacco, and Other Drugs section, John Haley, Ginny Chadwick, and Bob Bollinger, among others, brought together a number of local, state, and national partners to discuss the issue of tobacco control enforcement. And through a collaborative, consensus-driven process, the group landed on developing a series of aspirational principles to help guide state and local partners embed racial equity in the enforcement of commercial tobacco laws. The result was the joint statement that LaTroya mentioned a moment ago on tobacco control enforcement for racial equity, titled Decriminalizing Commercial Tobacco, Addressing Systemic Racism in the Enforcement of Commercial Tobacco Control, which outlines key values, recommendations, and equitable enforcement practices related to the purchase, possession, sale, and distribution of commercial tobacco products. So with that overview, I will hand things over to Del Monte to dive into applying the equitable enforcement principles in the context of commercial tobacco prevention and control. Del Monte, it's all you.
Thank you so much, Derek, for getting us started with that overview. Thank you all for having me and inviting me to this wonderful discussion and conversation. The Center for Black Health and Equity was at the table, as Derek said, with those 40-plus groups as we worked through this document and tried to figure out how we were going to decriminalize tobacco use. And so I'd like to talk a little bit about the center real briefly. You know, each year, as most of you know, approximately 45,000 African Americans die from a preventable smoking-related disease. And so this is what we work to address at the Center for Black Health and Equity. We are trying to reverse this burden, and we do that by building the capacity of communities of color to be able to advocate for policies that are going to promote optimal health. Now, how do we build community capacity? Of course, we have to address the intersection of health, social justice, and economic empowerment. These three things are all interrelated, and by addressing this intersection, we are able to build community capacity. We partner with traditional and non-traditional African-American civic and community-based organizations, and we want to hold systems accountable for developing equitable solutions for community empowerment. And so it made sense for us to be at the table again as we looked at how to have equitable enforcement and tobacco control. One of the things that our organization focuses on is the elimination of mentholated tobacco products. Now, why do we focus on menthol? Well, menthol focuses on us. Menthol focuses on communities of color. It focuses on Black and brown people. It focuses on those that are marginalized. And we get the data, and we know this by even just looking at the Surgeon General's report from 2012, which just highlighted a preponderance of data that showed how menthol was targeted to youth, how menthol was targeted to priority populations, how flavors are used to addict youth and other marginalized communities to smoking. So that's why we focus on menthol. Now, there has been this national movement that we've been a part in at the Center for Black Health and Equity in partnership with the African American Tobacco Control Leadership Council. And we've been at it for years. Since menthol was left out of the Tobacco Control Act in 2009, we have been advocating to get menthol banned and removed from the marketplace. Now, since Chicago passed the first ban on the sale of menthol-flavored tobacco products around the buffer zone of Chicago public schools back in 2013, there's been over 300 localities across the United States that have enacted restrictions on the sale of flavored tobacco products, and at least 100 of these communities restrict the sale of menthol cigarettes. Now, and there's also been 2 states, Massachusetts and California, that have passed statewide bans on the sale of menthol and other flavored tobacco products. So to say that there is momentum now, national momentum on restricting the sale of menthol and other flavors, this is very true. This is very true. We can see it happening. Now, that being said, the question becomes why we need to address equitable enforcement. And the reason and the answer is very clear. I mean, we have 3 cases here. And this is just 3 that I put up. There's other cases that we could pull and that we could talk about, but we have 3 cases right here. Eric Garner, Sandra Bland, and George Floyd. Now, what did these 3 individuals have in common, of course, aside from being African Americans? Well, each of them were approached because of some form of flavored tobacco product. Eric Garner was supposedly selling Lucy's when he was approached by law enforcement in New York. Sandra Bland was approached down in Texas because she was apparently smoking in her vehicle down in Texas. George Floyd supposedly was trying to buy a pack of mentholated tobacco products before he was arrested, before he was murdered on the streets of Minneapolis. So when we talk about addressing equitable enforcement, we have 3 individuals, all people of color, that were killed because of tobacco, we could say, or because, let's just put it this way, because there was not equitable enforcement of tobacco control. So even if for whatever reason, even if they did have a cigarette, even if they were trying to buy menthol cigarettes in Newport, even if Sandra Bland was smoking, if we had equitable enforcement of these laws, these individuals wouldn't be dead even now. Not only dead, I mean, look at what happened even in our case of both Eric Garner, who couldn't breathe and used those words, and George Floyd, who also used those words, I can't breathe. I mean, if we look at just some of the consequences, the incredible consequences of those actions, we had not just national, but we had worldwide protests against systemic racism, against, again, unequitable enforcement. And so to say that we need to do something about this, as this movement is building, to ban menthol and other flavors, as that gains steam, we want to make sure that these policies are put in place. And even in places that currently have policies in place, we may have to go back and revisit how they're being enforced, because we don't want to get to another place where we are systematically targeting African Americans or other people of color and creating opportunities for racism to rear its ugly head. Another reason that we definitely need to address equitable enforcement is because is right now the opposition has an opportunity to have some messaging that may resonate with communities of color. Reverend Al Sharpton, when he originally argued his proposal that it could lead more Black New Yorkers being targeted and harassed by cops for simply smoking menthol cigarettes. Now, we know that this is propaganda. We know that this is an argument that came to us from the industry. We know that the industry formulated this argument. They put it into members of our community to serve as spokespersons to deliver this message. We know that to be true. However, to those that may not be in public health, to those who may not know the industry's tactics, to those who may not know that, the tobacco industry sponsored this argument may resonate. This argument may carry some weight. Hey, wait a minute. We see Eric Garner harassed. We see him targeted by cops. So maybe we shouldn't put these bans on cigarettes. Maybe we shouldn't ban menthol or other flavors because this could give police officers an opportunity to target and harass our populations. And so we don't want to give them this argument by having equitable enforcement. Also Guy Bentley, the director of Consumer Freedom Research at Reason Foundation, he says this: beyond a basic sense of unfairness, there's the obvious point that criminalizing the sale of an addictive and profitable product will lead to the over-policing of Black neighborhoods, not to protect them, but to target them for these types of petty crimes. Again, yes, we know it's propaganda. However, again, to a non-public health professional, this argument could carry some weight. And I was even at a meeting that was held. I was at this meeting here where the National Action Network went to a church in Minneapolis, Minnesota. They were hosted by Pastor Billy Russell, and he had some of his folks with him from Noble and some other folks from Maryland policy initiatives that were speaking on the argument of criminalizing tobacco use. Now, fortunately, I was there in Minneapolis when this happened. I was able to talk to the pastor. I was able to get on the platform, and I was able to debunk this argument that they had. But these guys, these folks, they're all over our communities. We don't always know. We don't always happen to have a public health professional that can go in and say, no, this is propaganda, no, this is wrong, no, there's no data to support this. And they can make these arguments in these communities, in our communities, without being challenged. And so we have to address this, and we address it by really having equitable enforcement of our tobacco control. Equitable enforcement. So here we talk about, in terms of what's in this document, we've got some specific values. There's 4 primary values that we have. And first and foremost, these are public health measures. Commercial tobacco control laws and these policies, including regulation on the sale of these products, are public health measures. They're here to protect the public's health. They're not criminalizing measures. They're not here to punish. They're not punitive. These are public health measures. We're just trying to simply save lives. And so that's the very first value that is based upon. And state and local governments should reform and or eliminate laws or policies or any enforcement practice that targets the individuals, especially our youth. Again, this is not punitive. In the case of Eric Garner, this would not have been punitive because he had possession. He was possession. We don't want this to say these persons that are possessing these products should be penalized. We want any penalty to go to the retailer. And the penalty, again, this is a public health measure that we're talking about. And so we're not trying to throw people in jail. We're simply trying to protect the public's health. And value 3, the enforcement practices for violations should be proportional to the alleged violation and address health equity and social justice considerations. Extremely important. We don't need to blow things out of proportion. In the system that we currently live in, it is very easy for things to be blown out of proportion. It is easy for an individual to spend, months or even years in jail for possession of, say, a marijuana cigarette or a joint, and to spend years in jail for possession. This is possible in this system because these things are subjective. And because, yes, we're dealing with systemic racism. And because of that, we need to just make sure that any violation, any penalty is proportionate. And finally, the last value, state and local governments should adopt legal and policy frameworks that help to facilitate equitable enforcement of these laws by, again, holding businesses and the retailers and the industry accountable for violations, not those that are possession. Now, in addition to overall values, there are recommendations that we have that could make this work, that will make this work, and will make it equitable. First, we would shift enforcement from police or other traditional law enforcement entities to public health or other non-police entities. If this is a public health measure, then the public health entities should be responsible for enforcement, not the police. We would direct tobacco control funding to health entities to support tobacco prevention and control efforts, including those efforts aimed at the social structural determinants of health. So let's look at how do we take resources and put them back into communities to help these communities, again, enforce these issues within their communities. If individuals are smoking, if individuals are purchasing cigarettes for whatever reasons, well, how do we address why? What are the reasons why they're smoking? Is it unemployment issues that has individuals stressed out? Well, how do we put resources toward making sure we have employment so that an individual is not stressed? Is it housing? Is the housing, unsafe? Is the environment not conducive? Well, how do we change the environment? How do we put resources towards changing the environment? Let's address some of these other factors that make the environment conducive to smoking so that we can then reduce the need for folks smoking and therefore reduce the need for opportunities for folks to have to engage in purchasing or possessing even these tobacco products. Definitely we eliminate PUP, youth purchase, use, and possession, those PUP laws. They have to just be off the board, period. Eliminate any type of criminal penalties on individuals, including the retail clerks. I mean, the clerks, don't always own the store, it's the businesses. And if you go to the business, if you go to the owner, and if they have to pay the fine, then they're going to make sure that their employees are complacent with what they need to be doing. So, just let's look at who we're penalizing in these cases. And then let's ensure that tobacco-free school policies adopt, again, non-punitive restorative justice approach, eliminating laws regulating the possession, back to possession again, and create a supportive regulatory environment. So these are some recommendations that the policy, the statement that we have will provide us. Menthol itself, we know, is a social justice issue, and not banning it is an example of systemic racism. Unequitable enforcement only exacerbates the problem. And so, of course, we need to eliminate the predatory marketing to our populations, which again get us addicted to these products, and the dense advertising and the price discounts in focus communities, and the sampling vans and donations to our African American organizations and officials, and the sponsorships of our events, community events. But we also have to eliminate unequitable enforcement of commercial tobacco control regulations, as if we want to really turn the corner on menthol being a social justice issue and being an extreme burden on minority populations and communities of color. Now, that is all I have, and I think I turn it over from here to Counter Tools.
Thanks, Delmonte. Hello, everyone. I'm sure that many of you are now wondering about how to actually apply these equitable practices in your own work, in your own communities. And I'm going to talk you through that in just a second here. But I do first want to give you just a little background on where I'm coming from. So CounterTools is a public health nonprofit with the vision of a nation where healthy living is equitable across communities and every person has access to healthful choices. We work with our partners to advance place-based public health and health equity through policy systems and environmental change, through consulting on survey development and data collection, sign-our sampling, data analysis, agenda setting and policy identification, training on why the retail environment matters for health, policy change, message framing, collecting quality data, and more, through storytelling with reports, infographics, and maps, and through technology tools for data collection for prevention and/or enforcement, mapping, and retailer list management, and through supporting advocacy efforts in disseminating science and best practices. Our client partners are government agencies, nonprofits, universities, and educational organizations in more than 20 states. So to start talking about moving from concept to action here, I actually want to introduce you to one of our partners. And what better way to think about how these concepts could be applied than with a real-world example from a community that's done it. So I am honored to introduce Carrie Mcfarland, who manages the Multnomah County Tobacco Retail License Program in Oregon. Multnomah County adopted tobacco retailer licensing in 2015 and currently implements licensing, education, training, inspections, and enforcement for nearly 800 retailers each year. They not only ensure that enforcement is a civil public health function rather than a criminal function, they also have been very intentional in their approach and in designing the policy from the start. And Carrie is going to talk us through what that looks like. So from here, I'm going to turn it over to Carrie.
Thanks, Molly. Good morning. Again, this is Carrie Mcfarland coming to you from Portland, Oregon in Multnomah County. I do manage the Health Department's Tobacco Control and Prevention Program, which is home to our county's tobacco retail license. Today, I'm going to share examples of how we have considered equity in designing and implementing our tobacco retail licensing. First, let me share a little bit about our jurisdiction. Multnomah County is home to a little over 800,000 residents, and Portland is our biggest city. However, our metro region includes most of our county as well as parts of 3 other counties. As you can see from our demographics, we are mostly a white population. However, our county is the most diverse in our state. Like so many other places across the nation, our county continues to face challenges and disproportionately high rates of poor health outcomes in our communities of color and our high poverty neighborhoods, especially related to tobacco. As you may be aware, Oregon is one of the last states in the country that does not require a tobacco retail license. So let me share some of the history of how Multnomah County achieved tobacco retail licensing while considering the equity implications of such a policy and program. In response to alarming news in 2013, not only that Oregon had the nation's highest rate of illegal tobacco sales to minors, but that our own county's rate of illegal cigarette sales to minors was actually higher than the state average, our county commissioners realized they needed to take action to protect our youth. And like all good public health practice, we started with the data. My program conducted a retail assessment of tobacco sellers in 2014. We utilized our assessment to engage community partners from the Oregon Health Equity Alliance. Community organizations serving specific populations who are disproportionately impacted by tobacco-related harm recruited residents to join our staff in the field to raise awareness of tobacco retail settings and help us collect the data. The partnership with the Equity Alliance led to the Health Equity Impact Assessment of Tobacco Retail Licensing. Upstream Public Health, one of the member organizations of the Equity Alliance, received grant funding to systematically examine the potential health inequities of tobacco retail policy. I'll share more on the findings of the Equity Impact Assessment in just a moment. So after compiling data with the help of our community members and then engaging those same community members in the policy process through a series of public hearings, our county commissioners adopted tobacco retail licensing in November of 2015. Then followed the appointment of a Rules Advisory Committee of diverse stakeholders as well as an online public comment site so that any community member could weigh in on the development of the rules that would govern the tobacco retail license. Through the public comment period, we learned that 85% of our respondents agreed that our rules were likely to reduce youth access to tobacco and nicotine products, while 77% of our respondents agreed that the rules were fair to all tobacco and nicotine retailers. We began issuing licenses in July of 2016. Generally, we expect to issue about 800 licenses annually. However, due to the pandemic, our numbers will most likely be down. And I want to give a shout out to ChangeLab Solutions for featuring the role of our youth in the passage of tobacco retail licensing in a ChangeLab case study that I think was published back in 2017. So let me share more about the health equity impact assessment. The purpose of the assessment was to inform the policymaking process within Multnomah County and, if possible, our state's legislature. Now remember, Oregon still does not have statewide tobacco retail licensing. The goals of the assessment were twofold: to examine the racial, environmental, social, and economic health equity impacts of a potential tobacco retail license policy through understanding how such a policy interacts with health determinants, to develop recommendations about how to create a balanced policy that prevents youth access to tobacco while supporting smaller retailer economic vitality and positive health outcomes in our community. The work group and project team developed nearly 40 recommendations. This slide shows 7 of the priority recommendations related to the design process and the actual tobacco retail license system. As you can see from the table, each recommendation was scored based on environmental, economic, and social equity. Environmental equity looks at who is disproportionately impacted by the tobacco retail environment. Economic equity looks at those whose economic stability could be disproportionately impacted. And social equity is related to how social benefits are distributed or not across the population. I'm happy to say in Multnomah County, we've successfully implemented the first 6 of these recommendations. Our tobacco retail license price ensures that we cover the cost of a robust program that includes education, training, inspection, and enforcement. The license fee, as well as any civil penalties due to a violation, are paid by the retail owner, never a clerk. Our goal is to provide education, outreach, and training so that our retailers can be in compliance with all the laws, rules, and regulations governing the sale of tobacco and nicotine products. We provide online and, prior to the pandemic, in-person training, as well as on-site outreach and technical assistance. We utilize language services as needed, especially for our Korean language-speaking retailers, who make up 10% of our license holders. And of course, from a public health perspective, our goal is to reduce youth access to tobacco. During the public hearings and the health equity impact assessment process, we heard loud and clear from our community members that they were concerned about another policy that would result in unfair, targeted enforcement and punishment of certain retailers in certain neighborhoods. So in order to hold our policy and our practice accountable, we annually evaluate the Multnomah County Tobacco Retail License Program to identify quality improvement opportunities for program administration and to assess whether or not the program is disproportionately and adversely impacting small businesses or retail businesses owned by people of color. To do so, we built equity-focused indicators into our data system. On our license application, which is available in 7 languages, we ask our retailers to self-report their race, preferred language, number of employees, and annual tobacco profit. Preferred language is asked in order to provide educational materials and communicate with retailers in appropriate languages. Combined with our inspection, violation, and penalty results, these data are used to identify and address inequities in enforcement. We look at data for a single fiscal year, in addition to looking for any trends across the program's years of operation. Now let me provide an overview of our penalty structure. As was recommended by the Health Equity Impact Assessment, we issue civil penalties only to the license holder for any violation in the tobacco retail facility. Our penalty structure progresses by violation over a 5-year time period. The penalty fee amount increases, as does the license suspension period, ultimately resulting in a license revocation. In fact, during the undercover minimum legal sales age inspection, we do not collect any identifying information of the person who illegally sells the tobacco product to our under 21 youth inspection staff. Instead, we document the inspection by date, time, witness, and photograph of the location, as well as preparing the purchased tobacco product as evidence. At this time, we believe we've built a robust tobacco retail licensing program in Multnomah County that works to promote equity in our practice and prevents future health inequities by reducing the sale of tobacco products to our youth. However, there are some policy options that could do even more to address the long-standing harms of tobacco within certain segments of our community. Someday, I hope to share our success in restricting the sale of flavored tobacco and vape products, including menthol. How's that for a little teaser? I'm happy to answer any questions. Thank you for inviting me to share with you today.
Thank you, Carrie, so much for that really exciting example of how we can put these principles into action in a practical way. So I also want to recognize that many of you on the call may be in very different places in your policy work. So, these guidelines are aspirational. While they are concrete in their recommendation, what this looks like on the ground and the timeline for implementing them is going to look different in different places. Some places may not yet have licensing in place or may not yet be able to due to preemption. Some places may have a licensing structure but need to make alterations to shift how the enforcement is carried out in terms of the agency that is responsible and removing purchase, use, and possession provisions to focus on the retailer. Regardless of where you are in your broader tobacco prevention and control work, conducting a thorough review of any existing commercial tobacco control laws on the books in your state or local area is a great first step to identify where there are gaps or areas for improvement when comparing those as written against these recommendations. After identifying those areas for improvement, you can add and incorporate these principles and making those changes to the goals that you and your coalitions are already working toward. And like with most policy change, especially changes that have equity as a goal, it's important to start with engaging the community. So, finding out what people's lived experience with tobacco control enforcement is in your community, who is most impacted, and making sure that their voices are heard and they have the opportunity to shape what the solution looks like in your community. Share the statement with your coalitions and stakeholders and use it as a conversation starter. How can we work towards making sure enforcement of tobacco control laws in our community is not causing additional harm, but is truly working towards greater health for all members of our community? As you plan for how to make these changes, there may be some key windows of opportunity to take advantage of. In particular, for places that have yet to update their laws to raise the minimum legal sales age for tobacco to 21 to match the federal law, rather than just crossing out 18 and substituting 21, this is an opportunity to revisit the enforcement structure for underage sales, to add licensing if that has not yet been implemented yet, remove those purchase, use, and possession provisions, and ensure that enforcement responsibility is in the hands of public health. But some of these initial conversations may be difficult, and it's important to be strategic in how we approach them to avoid unintended consequences like some of those that Delmonte covered earlier. So many places may have good working relationships with law enforcement agencies, and shifting responsibility for tobacco control enforcement may require some careful conversations. Remember that the goal of this public health guidance is to reduce tobacco addiction and eliminate interactions between people of color and police officers that stem from public health laws, and to create public health policies that alleviate racial injustice in enforcement of tobacco control laws. It's not a comment on the other roles that police may play in a community or their overall budget. So maintaining a positive relationship with those agencies may be something that's important to you. Additionally, especially on a local level, relationships with retailers are also important. And the point here in shifting responsibility to the retailers is not to demonize them. As Carrie noted, and as exemplified by Multnomah County's approach, retailers are also stakeholders in the community. They are also often manipulated by the tobacco industry themselves, but they are also selling a product that is the #1 cause of preventable death and disease and making money off of it. And we need to make sure that they are doing so in line with the local, state, and federal policies, and to make sure that they are held accountable when they're not, rather than criminalizing youth for falling victim to the tobacco industry's pernicious and targeted marketing. While, as Delmonte talked about earlier, there have been attempts by the tobacco industry in the past to spread propaganda that falsely casts policies like bans on the sale of menthol cigarettes as something that would criminalize Black folks who predominantly smoke menthol. This guidance would further eliminate any of those concerns, with the recommendation to eliminate those youth purchase, use, and possession penalties and prohibit enforcement officials from initiating contact with an individual based on that individual's possession of a tobacco product. But we should be prepared for similar arguments to come up from the tobacco industry and their friend groups. But, remember, this really is about making sure that tobacco control laws and policies are centered on public health. So again, I want to recognize that in many places, figuring out how to implement these recommendations may take some time. Some of the recommendations outlined require investment of resources, and I know capacity may be a challenge, especially right now. There may not be an immediately available alternative to having police involved in the enforcement of commercial tobacco control policies in your community, and redirecting funds from tobacco taxes and the like to public health may require finding other sources of funds to replace them. It may take time to build the political will to make these changes, but we can figure it out together. In terms of taking an intentional approach, I think there's a lot of value in doing a health equity impact assessment like Carrie described, if that's feasible for your community. Consider also that community partnerships can be really key to ensuring that the voices of those most impacted in your community are heard, and in creating a sustainable structure for enforcement going forward. It's also important to monitor the implementation of these changes and track the outcomes. So consider from the start what your key indicators of success may be and what resources you have or can partner to find to do this type of evaluation. So as I mentioned, we can figure out what this looks like in your community and how to get there together. So, for general technical assistance on implementation strategy, messaging around these guidelines, counter tools along with the Center for Black Health and Equity and ChangeLab Solutions we're all here for you. And in addition, for legal TA in particular, figuring out how to write or rewrite your local and or state policies with these guidelines in mind, with strong policy language that will stand up to any challenges. ChangeLab Solutions, Public Health Law Center, the Network for Public Health Law are all really great resources. And the other CDC national networks would also be great resources to reach out to for technical assistance, especially for considering how current enforcement structures are impacting different priority populations and ensuring an inclusive approach moving forward. Lastly, I'll just highlight a few additional resources that may be of assistance. So there's a statement itself, of course, and then I know I haven't talked as much about the implementation of these recommendations as they relate to school policies around possession, but I will point you towards a really helpful model policy from the New Alliance for Healthier Generation and the American Heart Association that contains both background information and rationale, as well as model policy language that you can use for that. As Derek mentioned earlier, ChangeLab Solutions Equitable Enforcement to Achieve Health Equity Guide is a really great framework document for thinking about how enforcement of policies can create, maintain, or exacerbate health inequities and how to avoid those impacts and promote health and health equity instead. I also want to make sure to share the links to the health equity impact assessments done in Multnomah County. And then for some additional background on purchase, use, and possession laws in particular to help bolster your arguments for change, a couple of key resources here, one from ChangeLab Solutions and another from the Campaign for Tobacco-Free Kids. And then, so these recommendations that we've talked about today are focused on enforcement of commercial tobacco control laws around the sale of tobacco and ensuring that we are addressing the impact of systemic racism within current structures. When considering how to advance equity in retail tobacco control relating to tobacco sales, there are also additional policies that you could consider, including, of course, banning the sale of menthol cigarettes and other flavored tobacco products, but also pricing policies as well as tailored retailer density reduction policies. And you can find more information on those in our evidence summary on health equity and point-of-sale tobacco control policy on countertobacco.org. There'll also be some research coming from Dr. Alana Roskin at Stanford University on the benefits and barriers of using public health agencies to enforce retail tobacco policy. That research is just beginning, but again, we're all figuring this out together, and there'll be more opportunities to learn from each other in the future. So thank you for your time today. Please reach out if we can be of assistance. And I think at this point, I'm going to pass it back to LaToya for the Q&A here.
Thank you so much to all of our speakers. This is the Q&A portion, and so I just want to have this screen up so that you can grab everyone's email addresses in case you have further questions or want to follow up. I do want to note the misspelling of Carrie Mcfarland's name. There's no D, so please make a note of that error on my slide there. I do apologize. In fact, a couple of the questions were directly for Multnomah County, and so what I want to do is ask those series of questions first, and then there's a question that's really directed to everyone. Let's see. Oh, more questions. More questions have popped in as we speak. So I will start with this one that's for you, Carrie. How did this change the rate? And this is just referring to your presentation. How did the policy change the rate of sale of tobacco to minors in Multnomah County?
Yeah, thank you. That's a great question. So I made reference to the rate of illegal sales to minors back in 2013 that really got our commissioner's attention. And that was based on SINAR data. So in 2013, the SINAR data that was reported was that 30% of our retailers were illegally selling tobacco products to youth. Currently in Multnomah County, based on our own data in our minimum legal sales age inspection, we have a 16% failure rate. Unfortunately, since we started those inspections in our program, we have only moved from 15 to 16 to 14 to 15% failure for a few years now. Our goal actually is to be below 10% failure, meaning that during 10% of our inspections, our retailers would illegally sell a tobacco or nicotine product to a youth inspection staff member who is under 21 years of age. We hope to keep seeing a downward trend. Unfortunately, I will also share that since the start of the pandemic in March of 2020, we have not been in the field conducting our minimum legal sales age inspection, just like many other places around the country. So we are looking forward to being able to get back in the field and continuing to work with our retailers to help them be in compliance when it comes to the legal sales age for purchase of tobacco and nicotine products.
Excellent, thank you. Another question for you was, did Multnomah County have to get Board of Supervisors votes for TRL policy?
Excellent question, yes. So here we have a Board of County Commissioners. However, we had to start with what's known as our Board of Health. And our Board of County Commissioners is literally the same body that sits as our Board of Health. So when we started this process, we began with briefings in front of our Board of Health, highlighting the issues of tobacco and tobacco-related harm, disproportionately impacting certain segments of our communities, and in particular our youth, convincing the Board of Health that this was a public health crisis that needed attention, and one way to address the rate of tobacco sales and access to youth and the resulting health inequities was to put in place a regulatory structure to help our retailers comply with all the laws that govern the sale of those products, and most especially the laws around the legal sales age. So we started with our Board of Health. They passed an ordinance calling for tobacco retail licensing, and then it did go to our county commissioners in order to pass the policy unanimously.
Thank you. Okay, this next question is really directed to any of the speakers. She says, has equitable enforcement been addressed with the FDA enforcement program? Can anyone speak to that one?
I can weigh in a little bit. This is Derek. So I think there are some structural factors that sort of gave the FDA enforcement program a little bit of a head start in terms of some of these equitable enforcement practices. So, for example, right, because federal tobacco control laws are focused on the industry actors, the retailers, the manufacturers, the distributors, it inherently means that there are no youth purchase, use, and possession penalties on the books at the federal level, and thus inherently the FDA's enforcement program is not enforcing those laws that we know to be inequitable. I think there are probably broader questions that could be asked and answered on that, in terms of looking at patterns of where inspections are taking place, if there are a greater number of violations in certain communities over others, and how those are addressed. But sort of on the 1,000-foot level, it's starting off in a much better place than in many instances because of those because of the lack of some of those more inequitable components at the federal level versus more wide prevalence at the state and local level.
Got it. Thank you for that. We have some time on our hands, so I'm going to answer two more of these questions, or I'm going to pose them for you all to answer. This question is a little bit longer, but it's for everyone, and I think it's a good one. It says, equitable enforcement is super important for smoke-free air laws, especially parks, colleges, and downtowns. In those cases, there's not much we can do to target businesses and industry. These are cases where if the policies were enforced, they would be enforced against tobacco users. How can we ensure equitable enforcement in these cases? For example, how do we not further exacerbate the circumstances of a homeless person when trying to enforce a smoke-free parks policy? What are some options for enforcement without bringing in police at all? So the question is really about how to ensure when there are cases that it's going to impact tobacco users.
Yeah, this is Del Monte, LaTroya, and I saw that question, and all I could see was another webinar. That is another webinar of its own, because now you are talking about possession. You are talking about police or whatever your enforcement options are, having interactions with individuals. Now, if we did equitable enforcement of commercial laws, and if we said, well, wait a minute, it's not going to be the police departments that's doing this, but it's going to be some, say, public health official. Well, it would be those same officials if we took, police out of the equation in general. It would be those same public health officials that would try to enforce the law. Now, to be quite honest, this goes back to one of those recommendations that we had, which was direct tobacco control funding to health entities to support tobacco prevention and control efforts, including efforts aimed at the social and structural determinants of health. If the individual is homeless, how do we get the individual off the street? How do we get them from not being homeless? This then becomes our equitable islands. This is what we're looking to address more so than the fact that they've got a cigarette. The fact that they've got a cigarette is minor to compare to the fact that this person is homeless. Why are they homeless? What can we do to address the homeless situation? And that should be where the funding goes, and that should be where the focus goes.
Yeah, I'll just add one point on the end of that, right, of even if it's being enforced on that, right, we can think about what penalties for that actually are. So, not imposing civil penalties or criminal penalties on those actors, but providing them resources on where they can access free, culturally appropriate cessation services and things of that nature. So really focusing on how can we be supportive and address the underlying addiction issues and as Del Monte mentioned, the underlying social and structural determinants, rather than really focusing on it being a punitive response for those violations.
Great, everyone. Okay, for the last question, it says, I read an op-ed recently that suggested menthol bans were white saviorism. I see some flaws in this argument, but as an aspiring ally, I am open to hearing when my stance is problematic. Wondering if the presenters have any relevant thoughts to share about this.
Yeah, this is Del Monte again. Back in 2009, when the FDA failed to include menthol in the Tobacco Control Act, the National African American Tobacco Prevention Network, our organization, and the African American Tobacco Control Leadership Council, the organization with Dr. Phil Garner and Carol Magruder and Dr. Valerie Yerger, were the first individuals to come out and say this is wrong. We need to address this. And so that's when this whole effort to include menthol and to reverse this track started happening. This wasn't a white savior trying to come in and help us. This was Black organizations saying, hey, wait, this is going to have a negative impact on Black people, and so we need to do something about it. And so, yeah, I don't see a white savior kind of argument here, only because the organizations that were in this from the beginning, and even when flavor restrictions and menthol flavor restrictions weren't cute and sexy in terms of what they were trying to address from the National Tobacco Control Movement, our organizations, NAPTN and the AATCLC, kept saying, wait a minute, we need to address menthol, we need to look at menthol, and we kept working on menthol. Our organizations were there when the very first menthol ban was placed in Chicago back in 2013, and our organizations have been instrumental in every menthol legislation that has passed ever since. And so, no, this is not a white savior argument. This is our communities trying to save our own lives and other lives as well. Thank you.
Thanks. That was great. I am going to allow us to conclude here, but before I do so, I want to toss it back to Derek Carr and make sure there aren't any final words or thoughts you'd like to offer up.
Sure. Thanks, Latoya. I want to thank everyone for joining us today. This has been really great and really the start of a conversation, not the end of it. So we look forward to working with all of you in the months and years ahead to really put these principles into practice. And with that, I think that we are concluded for today, and thanks again for everyone joining.